Good afternoon, everyone, and welcome. I'm Sally Davies, an editor at Aeon magazine, and it's my pleasure to welcome you to today's panel discussion on the ethics of placebo use in psychedelic research. So before we begin, just a brief bit of housekeeping. We're going to try and keep the discussion to around 60 minutes. So in the first half hour, we're going to introduce the panelists and I will ask some questions. And in the last half hour, 20 minutes or so, we're going to open up the floor for discussion. That said, please do feel free to drop your questions in the chat throughout, and we'll see those coming through and pick them up as appropriate. I do apologize in advance. We can almost never get to everybody's questions, but we'll look forward to hearing from you. So to the topic today, psychedelic research represents one of the most fascinating frontiers in modern psychiatry and neuroscience. After decades of prohibition and neglect, substances such as psilocybin, LSD, and MDMA are being rigorously investigated for their potential to treat conditions ranging from depression to PTSD and addiction and end-of-life anxiety. Yet this renaissance brings with it a fundamental methodological challenge. How do you conduct a gold standard clinical trial on a substance that announces its presence so unmistakably? The randomized, double-blind, placebo-controlled trial has long been our most trusted tool for separating genuine therapeutic effects from the powerful influence of patient expectation. But when participants can immediately tell whether they've received a psychedelic or a placebo, as the walls begin to breathe or colors to intensify, the very foundation of this methodology comes into question. This challenge forces us to confront profound questions about the nature of healing itself. If a treatment's efficacy is partly driven by the patient's belief, the therapeutic relationship, or the meaning attached to the experience, how do we distinguish between drug effects and placebo effects? What does the intensity of psychedelic experience suggest about the ethics of placebos in other instances? And what does it mean to seek informed consent for an experience that words can often barely capture? So I'm now going to introduce our three panelists who will be able to tell you more about their points of view on this subject. Dr. Matt Butler from King's College London, Dr. Matthias Liechti from the University Hospital Basel, and Dr. Daniel Villiger from the University of Zurich. Welcome to all of you. I'm just going to go in the order that I see you all on my screen. So Matt Butler, that is, would you like to start by introducing yourself?
Yeah, thanks so much for the introduction. I'm really great to be here talking about a really exciting topic, I would argue. So as I've been introduced, I'm a researcher. I'm also a clinician, so I'm a psychiatrist by training. And I've worked for a few years now on different clinical trials of psychedelics for different conditions, mostly in depression, but in other wide-ranging conditions, so headaches and PTSD and other things. So I suppose I'm kind of in the kind of the front end of the kind of clinical delivery of psychedelics in the research setting. But also as a researcher, I'm interested in the kind of wider questions that are being asked by psychedelics and that we're asking of psychedelics. I think the key things that we're going to touch on, I suppose, have already been mentioned, but this sort of functional unblinding, which is the phenomenon whereby people are unmasked to their allocation in different arms, so either in the active arm, the psychedelic arm, or the placebo arm. So this is something that we do see play out in the trials that we work on. We're speaking to participants who are very often aware of which arm they've been allocated to. And this has attendant effects potentially on their response to the psychedelics. And it often means that people in a placebo arm might be a bit disappointed. And so I'd like to have a think about how this might implicate or what implications this might have on how we interpret the evidence from the trials that we're running. It's likely that this sort of design that we're using, the randomized controlled trial, is going to overestimate the effects of psychedelics. And what do we do about that? I guess I would put myself in a kind of bracket of being a pragmatist. So I would say that we just have to acknowledge that. We have to try and mitigate the effects as much as possible, but I don't think it's anything that we're potentially ever going to get rid of or ever going to, be able to completely nullify from the research. So I suppose it's thinking about what we do in the context of this when we're thinking about psychedelics as potential treatments. And of course, just to quickly mention, when we're talking about psychedelics in trials, it's not just the drug. Or it rarely is, it's usually a drug plus therapy. And of course, that leads to sort of difficulties in how we think about these as treatment packages, but also how they're going to be licensed and regulated if that ever happens.
Thank you so much, Matt. That's so helpful and always really fascinating to have the perspective of someone working on the clinical front lines, as well as being able to see the bigger picture. Matthias, you're next on my screen. I'll let you introduce yourself.
Yes. I am a medical doctor specialized in internal medicine and clinical pharmacology. We are conducting several clinical studies with psychiatric patients, mostly depression, anxiety, in collaboration with the psychiatrists. We also have trials in patients with cluster headache, and we recently completed one in patients with ADHD. We are using a variety of psychedelics in the studies. In the patient studies, it's mostly LSD, but we consider LSD and psilocybin very similar according to the research in healthy subjects that we also conduct. We are also using a lot of different approaches with regards to the placebo response. So that could be lower doses that are included or inert placebo, but generally all the clinical studies that we run will include a placebo if we're interested in the response of a psychedelic compared to let's say, a normal state. Sometimes studies are being conducted without a placebo if we are more interested in an interaction, for example, how an antidepressant would alter the response to a psychedelic. Then we would say we are just looking at the psychedelic response with an antidepressant and then blinded with a placebo. But in both cases, the patients or the participants know that they will receive the psychedelic, and the placebo is essentially then the control for the other substance that we are adding. So there may be a variety of different designs and roles for placebo and also different aspects with regard to unblinding. For example, if we use a study with low dose LSD in patients with ADHD, then the subjective effects are minimal, and accordingly the blinding may be much different from a high dose study. So this is something we can also then discuss.
Fascinating. Thank you so much, Matthias. And Daniel, you're last on the hook.
Yeah, thank you so much for the invitation. It's great to be part of this meetup. So I'm a philosopher at the University of Zurich, and in the last few years, my main topic was bioethics, and here specifically psychedelics and psychedelic-assisted therapy. And my starting point was informed consent. So more or less what you said in the introduction in a few words. So the question whether you can even give informed consent to a psychedelic experience, because the experience is so ineffable if you have never had it. How can you get an understanding from reading an informed consent form and really have a good idea of what you are willing to do here? So that was the starting point of my bioethical research into psychedelics. And contrary to a prominent position in the field, I said that informed consent is still possible. So I wasn't very skeptical about that. But yeah, this start into the whole universe of psychedelics was really an interesting world that was going up, and I started to look at many different ethical problems or challenges in the field. For example, how we can protect vulnerable patients during the psychedelic session, how we can protect them from manipulation or potential manipulation from the therapists, whether therapists need psychedelic experience themselves to properly make the therapy. And also one question is the one of how we should use placebos, or how psychedelics should be studied. And here my first thoughts about it was that I read proposals how to solve the problem of blinding in psychedelic studies. And a few of these proposals included concealment or deception of patients. And of course, then from my bioethical perspective, this is something rather problematic. So yeah, I thought that these proposals that use concealment or deception are not really a solution to go. And when I went more into the whole topic, I also started thinking that actually, if we stick to this double-blind randomized control design, then we also kind of just looking at the pharmacological aspects of psychedelic assisted therapy, and we are neglecting the whole therapeutic aspect and psychological aspects. And because of that, I got more and more skeptical that we should keep the gold standard of double-blind randomized control trials in psychedelic research, at least if we have high doses of psychedelics, and rather see these as one of several designs that have similar relevance in the field.
Okay, very, very interesting. Well, look, there's a lot to unpack here. I think one of the things I'd like to start with, which was new to me while I was doing preparation for the panel, was this concept of super placebos, and this idea that psychedelics are this kind of, I think some scholars have described them as kind of an active super placebo because they dramatically amplify things like the therapeutic context, expectations, and patient suggestibility. So I guess I'm curious for your thoughts as a panel on if psychedelics do work in large measure or partly by enhancing the mind's own healing mechanisms through belief and meaning making. How does that change their ethical status with respect to other pharmaceuticals? I'm curious to have the panel's sort of responses to that question.
So I'm happy to start with a response to that. Just to firstly say that I think it's a very good point that psychedelics could be exerting a lot of their effects via modulation of mechanisms that are implicated in placebo responses. So I think the kind of commonly held like idea about placebo might be that it's a sugar pill and it's just almost thinking yourself better. But we know that there's extensive placebo research to suggest that it's a very, very complicated phenomenon that involves expectations about treatment, but also environments, previous experiences with illness and treatments, sort of general mindset, interactions and rapport with clinicians and therapists. And all of these factors are really kind of amplified in psychedelic research. So there's evidence to suggest that the physical environment in which one receives a form of treatment, whether that be medical or not, has an effect on response. So if you're in a nice surrounding, particularly if there's access to nature or good views, or it's just relaxing, people can do well. And in psychedelic trials, we deliberately manipulate the environment because we know how suggestive or susceptible people can become to their environment in the psychedelic effects. So we make the rooms nice, we have curated playlists, we give eye masks. And so these effects are pronounced in the psychedelic experience. And it may be that the psychedelic itself is a kind of conduit through which these experiences exert their effects through very similar mechanisms. I suppose then the question is, if that is the case, if they are just big placebo modulators, should we be fatalistic about this and say they're just placebos? Whereas I think what actually that teaches is that these effects are enormously important, generally, I think, potentially, particularly for psychedelics. But I don't see that as a reason to lose faith in the potential for psychedelics to be treatments.
I mean, an interesting point of difference here, Matt, and I could be wrong about this, but I sort of sensed from your initial remarks that maybe you were more generally optimistic about the utility of randomized controlled trials within psychedelics research, whereas Daniel, you were suggesting, maybe just knocking them off the pedestal, not necessarily doing away with them entirely, but they're not necessarily the default method for testing therapeutic efficacy. I was also curious, sort of beyond this question of sort of the efficacy of randomized controlled trials in this context, are there situations where, because of the arguably unique nature of psychedelics, that actually randomized controlled trials become unethical, quite aside from whether they're actually going to be effective at testing the therapeutic benefit? Is that something, Daniel or Matt, that either of you would like to speak to, or Matthias for that matter?
Happy to respond, but I don't know if you want to go first, Daniel.
So I wouldn't say they are unethical, but I think it really depends on what we are studying, whether they are useful or not. So if we want to study what makes psychedelic-assisted therapy therapeutic, then we need double-blind randomized control trials, because only with this design we can really get causal inference. However, the problem is that if we try to take psychedelic-assisted therapy as a whole and then make a double-blind randomized controlled trial with it, then it's just too many factors that are that we will need to study, but we can only manipulate one. So usually when you have a placebo or some other a treatment group, so you have the treatment group and you have like the control group, then you manipulate one thing. If you have usually for example, then you have the inert placebo and the psychedelic. So then you are manipulating this one factor. But if we look at psychedelic assisted therapy from a more holistic perspective, it's not just the pharmacological intervention, it's also the psychological intervention. And you do not control the psychological intervention, or at least not the interaction of the psychological intervention with the pharmacological intervention. So I would say it's ethical to use double-blind randomized control trials, but we can only use it to manipulate one thing. For example, you can manipulate how high the dose is, or you can manipulate maybe expectations of participants, or you can manipulate the therapeutic surrounding. And each of these studies will tell you something about the therapeutic causes of psychedelics. But I don't think that one study can tell us all of it.
I think I would agree with a lot of what Daniel's saying, actually. I think I sort of still give tentative support to the RCT model for looking at psychedelics, because I don't think there's been anything that's been proposed that would supplant that as a means of evidence generation. But I think that it's definitely true that the psychedelics are an imperfect fit for RCTs. And that we should be thinking creatively about other ways in which we can gather evidence to support the findings from RCTs. And like I said, I think we should actually temper our enthusiasm for results from RCTs, because I think they likely inflate any particular responses. I think that I want to be wary about kind of psychedelic exceptionalism. I think they're asking some really interesting questions. I don't think they are always as unique as perhaps is held. I think they're really exciting and fantastic, and they do highlight particular challenges. But there are other areas of medicine in which unblinding and sort of RCTs are difficult. So I'm thinking here about things like physiotherapy, and that involves an active intervention. Psychological therapy, as has already been pointed out, it's very difficult to test that for an RCT model. And in some cases, even surgery, it's difficult to do blinded surgical trials on people. And yet these disciplines are flourishing, and there are different ways of collecting evidence. And there's perhaps a lot more historical precedent, but it's not the first time in which we're facing a difficulty in gathering evidence for a particular intervention across the whole field of medicine.
Look, I think this is a nice moment to bring Matthias into the conversation, because, of course, Matthias, your work, you've looked at some sort of creative trial designs to get better blinding. You mentioned using these kind of sub-perceptual doses or active placebos. So people might feel something, but they're not sure which arm of the experiment they're in. I was wondering if you could talk us through any more of these kind of innovative structures and how broadly applicable you think they might be.
Yeah. So first of all, what is the placebo effect? It's an effect that is similar to the control, to the psychedelic. So if we have two groups, one receives the psychedelic and one receives the placebo effect essentially is an effect that is similar to the effect of the psychedelic on whatever outcome you are measuring. And what we have observed with high-dose psychedelic studies is that the placebo effect is smaller, not larger. It's smaller than maybe with studies that are using, for example, an antidepressant in patient with depression. So what does that mean? We see a smaller placebo effect, most likely because there is unblinding, meaning that the patient realizes that he got placebo and therefore thinks, okay, I'm not going to improve, so the effect is reduced. And there has been a study showing that indeed in a larger group of psychedelic trials that are using a placebo group but do use an inert placebo, that the placebo effect is smaller than in other clinical studies. So that is essentially the concern, and how Matt said already, that inflates the therapeutic effect. It's inflated because of the unblinding. So solutions that are required by the regulator to kind of adjust for this, because we can discuss a lot about possible trials here. In the end, it's the regulator, meaning FDA, EMA, Swissmedic, who will judge whether a certain trial will essentially then lead to market access or not. So regardless of our opinions, that essentially gives us what we have to do if we want to use these treatments in patients. And options to reduce the placebo effect, or to actually increase, you could say, the placebo effect and decrease the unblinding, so improve the blinding, would be to use, for example, a small dose of the psychedelic. And then the patients cannot distinguish between the small dose and the high dose. And you may see, however, a small therapeutic effect already with the small dose. So such a trial would actually require either an additional trial with an inert placebo to know what the effects of no dose would be, or even 3 arms or more arms, meaning an inert placebo, a very small dose to enhance the blinding, essentially to add confusion, etc., or even several doses. And if you're looking at trials that use several doses, ideally you would then see an increased effect by the high dose and smaller effects by the small dose, and potentially a bigger placebo effect because people were not sure about whether they received a small dose or indeed placebo. Now, for example, in our ADHD study, the blinding was very good because they got small doses of LSD compared to inert placebo. And the result was that both groups had high effects. So you could say they had a high placebo effect, not much unblinding. And that is not what you want as a company or as a researcher, because you are kind of increasing the placebo effect, and there is no chance that there can be a therapeutic effect of the substance that you are studying, because everybody is highly convinced he got the real treatment. He is exaggerated, already has high expectations from all the media, etc., and it will be essentially impossible to improve. What you would want is actually a very bad physician, bad nurses, and a very bad treatment, so that there is essentially a small placebo effect and a true response to the psychedelic. And one approach to this could be, coming back to Daniel's conclusion, that there are many factors involved with psychedelic research. One approach was used by Mind Medicine. They just said, essentially, we are not doing any psychotherapy. We are just giving LSD in different doses compared to placebo. And a person will sit in the room with the patient, making sure that they are not kind of getting out or whatever, jump out of the window. Nobody does that. But essentially, there was just some person in the room. If somebody was kind of getting anxious, they were comforting and saying, okay, I'm here, no problem. But there was no psychotherapy, they argue. So they kind of removed the additional effect of the psychotherapy, or at least kept it minimal and the same in each treatment group, whether high dose or low dose. So that was one approach to reduce expectations and to reduce non-pharmacological factors. And they still saw a nice dose response, meaning high doses were stronger than low doses and were stronger than placebo. And another approach, and I will end with this, is that you have independent raters who are fully blinded. So they are not allowed to discuss with the patients whether they think they had LSD or not. They're just there to rate the depression at this time point. They may not even know whether it's kind of at the beginning or at what point during the study. So at least the assessment of the patient is blinded, and the raters were blinded. They were not knowing whether, even after the study, you can do an assessment of the quality of the blinding of the raters, not of the blinding of the patients. These are all measures that are proposed by the regulator to kind of increase the validity of the results that we are generating.
Yes, I mean, it's a good reminder that ultimately for these therapies to reach patients in the real world, they need to satisfy regulators. So it doesn't matter how many creative frameworks we come up with, unless, something is acceptable to a regulator in terms of an evidence threshold, then it's not going to make it to market. I think it's very interesting what you say about the unblinding, not just from the patient's perspective, but from the clinician's perspective or the researcher's perspective. And I wanted to unpack that a little bit too. And very interesting what you say about these assessors who come in, don't know what stage the research is at in the process, to sort of add this protective layer. I mean, Daniel, you mentioned just in passing now this question around the importance of people conducting psychedelic research having psychedelic experience themselves. I was wondering if you could unpack your point of view on that question. How important is it? And why is it important? Does it have to do with this unblinding question around the researcher's assessment of the effects, or is it important for other reasons?
So traditionally, like in the 60s, it was very much the case that therapists argued that you need to know how it is to go through a psychedelic experience to help someone else go through it. So you cannot be a guide of a journey if you do not know the territory. That's why you need to have psychedelic experience yourself. So I think that was very much the commonly shared among psychedelic therapists. Now today, this idea is still around, but it's a bit, and I would also say many psychedelic therapists do have psychedelic experience themselves, but there's a more critical debate at the moment in bioethics, whether this is really justified. So whether people trained in psychedelic therapy should have this as part of their training, like a personal psychedelic experience. And the problem is that if you have such a regulation that you would need that you impose it on people that maybe do not want to have such an experience, or maybe have a medical condition that is not allowing such an experience. So yeah, the question is it still ethically justified to say that psychedelic therapists do need it? And at least so far, it's hard to justify it, I would say, because we would need to have clear empirical evidence that shows that therapists with psychedelic experience, personal psychedelic experience, have better treatment outcomes than those that do not have personal psychedelic experience. If that were the case, if we had such evidence, then we could say, well, we see it makes a difference regarding patient outcomes, and because of that, because we have an obligation of beneficence for patients, we can impose this regulation that this is mandatory for psychedelic therapists. But such evidence is missing at the moment. So I would say we cannot, it's not to make it obligatory is not justified, but still I think it should be optional during training that you can have a psychedelic experience, because both psychedelic therapists and also patients say that they benefit from the personal psychedelic experience of the therapist. So there is a benefit, at least from self-reports, but we do not know whether this benefit also translates into treatment outcomes. And I hope there will be a study on that soon. But at the moment, yeah, evidence is inconclusive, and therefore, yeah, I do not know whether it really has an impact on it. And only if it truly has an impact, only if personal psychedelic experience of the therapist truly benefits the patients, then we can make it obligatory for therapists.
I'm curious for Matt and Matthias, your as practitioners yourselves, what's your take on this question? And I'm also curious as to whether the presence or absence of personal psychedelic experience for the clinician changes the ethical relationship between the clinician and the patient, or maybe it doesn't, but I'm curious for your response.
Yeah, I think it's a really tough one because there clearly is this ineffable quality to the psychedelic experience that I think one needs to have personal experience of in order to fully understand. I've been a healthy volunteer in a clinical trial of psychedelics, so I kind of had my own experience, and I think that in a way that did help me understand the participant experience in a way that it's difficult to just access verbally through information. But then I don't think that should be mandatory, certainly, again, for the reasons that Daniel has very eloquently already stated. And also particularly the country like the UK, where there is no political appetite and these are still, class A drugs and there's no political appetite to change that, there'd have to be a lot of things changed for that to be the case. I think that it's a lot of the response to psychedelic, if we're thinking about these being these placebo modulators, are through these kind of common factors of psychotherapy, which are the kind of aspects of people's response to psychotherapy which are not due to the specific intervention. It's just due to mostly having a nice therapist who understands you and the time that they give. I think it's very possible for a therapist to be warm, engaging, and with the patient on a journey through a psychedelic experience without any personal experience. So I don't think it would completely attenuate any potential effects that it might have, but there may be a degree of just deeper understanding of the experience if they've had their own personal experience. So yeah, I'd roughly agree with Daniel, I think, again.
Matthias, did you have any views on that?
Yeah. So in Switzerland, the self-experimentation would not be legally possible. However, in the training program currently offered by the SEPT, one of the professional societies, there is an attached research program looking into the effects of self-experience on therapeutic alliance, etc. So there has been a research project kind of accompanying this training and essentially offering self-experience with MDMA, psilocybin, and LSD, which are the three substances available to therapists in Switzerland, to these persons in training, currently 24 over 3 years, and another 24 starting, I think, soon. And as far as I have been informed, so it's obviously not mandatory, it's fully free to participate. There cannot be any pressure or group pressure, at least not at all, on the possible participants, but apparently most, if not all, these trainees were participating in the self-experience. So that's an interesting aspect and also way how it was made kind of legal to the therapists who have this experience. But coming back to the point of if you want, let's say as a pharma company or even as an academic researcher, if you want to show that, let's say, psilocybin is more effective than placebo, you want to have trip sitters or psychotherapists, whatever they are, who are really bad. They should not be convinced of the effects of the treatment. They should not have high expectations because they have used it themselves and are already convinced that this is positive, there is a higher risk of persons who have used psychedelics that they're just enthusiastic about them. So as a company, I would actually select the worst therapists that I can find who even believe that there is no benefit at all, and then have the patient treated. And then if this study shows you, and it's actually more likely to show you a beneficial effect of the psilocybin, if there is any, because you are reducing the placebo response again. So for the clinical study, you want the worst therapists. For the clinical practice, you want the best. And of course, then you want to enhance the placebo effect. But if you want to show first to the regulator that these treatments work, don't be enthusiastic about their effects. You are doing harm to the efficacy of the substance if you are convinced it works and if you make the patients convinced it works.
I mean, I guess that interpretation, as interesting and provocative as it is, raises the question in my mind as to whether it is really possible to disentangle the pharmacological effects from the contextual effects. Because, I mean, you could see a scenario where the clinical improvements or therapeutic benefits for a patient only exist when two of these elements are put together, and they're not necessarily kind of adding up with each other in a linear way. I mean, that may not be the case with
yes. So that was what Daniel referred to as the interaction. So you can potentially take out the effect of the psychotherapy by just having the same therapy or context in both groups, the placebo group and the psychedelic group. But there may, as you mentioned, there may still be an interaction. So essentially the psychedelic only working in the presence of a certain context. Well, to do that, we need studies. So far, we have. So if you ask the question, do we need placebo-controlled studies? Yes, of course, because there are almost no placebo-controlled studies, but there are many studies just showing an effect improvement over time without the placebo, which is completely useless. And the next step would be to have factorial designs adding placebo versus, let's say, psilocybin, and then adding psychotherapy, no psychotherapy. So you have these two factors, and then you can also assess the interaction. So you change, essentially you have two groups that have the same active and placebo, and you have two groups that have one of the context factors change, for example, psychotherapy, and in the other case, you're just putting in some puppet or person who is not neglecting fully to interact with the patient or whatever.
I mean, that starts to feel like a bit of an ethical minefield, though, if you're, if I'm then being put in a room with someone who's not necessarily therapeutically trained or who's like a terrible therapist.
Doesn't matter. It's not unethical. Why should it be?
Daniel and Matt, do you agree? To be put in a room with a puppet therapist as part of a creatively designed trial?
If you agree to participate.
Complicated. I think personally that the therapy side of things is enormously important for response. And I think I'd feel a little bit uncomfortable without that. But I think that's partly because I haven't been in a situation where that has been trialed. And I'd certainly agree with the suggestions that in order to bolster the evidence, we need to think about actually testing whether or not these therapies are necessary. And I think that is happening now as the pharma companies start to look for partially for cost-saving exercises, sort of reducing the therapy or having less therapists or less therapy time. So we'll start to see these factors play out. I don't know if I'd be brave enough as a clinician at the moment to think about putting a patient particularly in without any therapist. Certainly for healthy control, I think it's a different matter. But I don't disagree that it would be asking or trying to answer quite important questions about the pre-regulation phase of psychedelics.
I think part of the real challenge here, isn't it, is we're coming to recognize the fact that in order to improve the standard of evidence about the effects and interactions of these different interventions, we may need to accept ethical trade-offs in other domains, essentially, because, these are human beings coming to these experiments with their own life experiences, hopes, expectations, especially as, Matt, you've looked at in your work, the effects of the kind of media hype. You mentioned this too, Matthias. So I think, maybe there's a sort of discipline and societal wide conversation we need to have about what we value more, like standards of evidence or, patient outcomes. Really complicated. I wanted to turn, if we could, to this question of informed consent, because you mentioned this, Daniel, and I think it's really fascinating. You mentioned you'd kind of come down with this contrarian view that it was possible, in fact, to get informed consent for psychedelic research. So I'd love you to unpack that a little bit more. And then I just wanted to pick up on this really interesting question that's come through from Ashwin, where he's mentioned that there's some evidence that virtual reality can work as a psychedelic analog measured according to the Mystical Experiences Questionnaire. And Ashwin wanted to know what the panelists' views were of using tech like VR as a patient education or sensitization tool to address the challenge of informed consent. So maybe, Daniel, you can start by putting forward your rearguard action on the value of the possibility of maintaining informed consent with psychedelic research. And then the panel could talk to this question about whether or not VR can be a good kind of substitute or a support for some reimagined notion of informed consent.
Yeah, so the main argument from Jacobs against informed consent in psychedelic context is that in order to give informed consent, you need to be able to make a value-aligned decision. And for him, a value-aligned decision is more or less the same as a rational decision. And in order to make a rational decision, you have to be able to anticipate the possible outcomes of your choices. So if you choose to undergo psychedelic-assisted therapy, you need to be able to anticipate what is the value of undergoing this psychedelic experience, and how will it affect your life, and so on. And he says, since a psychedelic experience is so outwardly, so it's really, and I think this is true, it's really hard to imagine what it's like to undergo a psychedelic experience if you never had one. So it's really putting you into a complete, if it's a high dose, into a complete different world, so to say. You sense the world in a quite different way, and also yourself. And he says, since this has these transformative qualities, the psychedelic experience, we do not know its value. We cannot understand what it means for our life, and therefore we cannot give informed consent to it. So that's like his argument why it's not possible. And first, I would say this is not only true for psychedelics, but also for other treatments, medical treatments, where you do not really know what they will mean for you. So, for example, if you undergo chemotherapy, this can also be very a transformative experience, and you may not be able to really, anticipate how it will affect you. But still, no one says that you cannot make this decision on your own. And so that's like one point, that psychedelics, even though like the experiential aspect are quite unique, it's not an exceptional situation that we have here. And then the other thing is that I don't think you need to know everything in order to give informed consent. What is important, that if there is ignorance that you cannot reduce, so for example, you cannot know how it will feel like to have the psychedelic experience before you have it. So there is ignorance that is irreducible. That if the clinician addresses this ignorance and points out that this psychedelic experience might be transformative, it might affect you in ways that you cannot appreciate at the moment, that this is enough. So knowing that there can be irreducible ignorance is enough to give informed consent, and you do not really need to know all the aspects of your future outcomes.
And so, Matthias and Matt, do you agree? What's your view on informed consent? And I'm really curious to know kind of what you think the possibilities are for VR technology, and whether that's something you'd ever sort of consider integrating into research or practice.
So regarding the informed consent, so a psychedelic experience is not something very usual or normal, but it's having a transformative experience is not absolutely exceptional. I would say there are many such experiences. If you sign up for a mountain climb, it doesn't have to be Mount Everest, but pretty sure you're going to have fear and experiences that maybe you have not anticipated. If you give birth, that's something that happens quite frequently, and you usually I've heard from women that they didn't really know to what they signed up. Even falling in love, all these situations are quite well happening and are transformative and overwhelming, and that's life. And I think absolutely you can consent to something of which you don't fully may be able to already know what it is before you sign up. And then one solution could be, for example, that you start low and go higher. So maybe, of course, a study could be considered unethical if we treat patients the first time with 60 milligrams of psilocybin. So maybe you start with 20 and then only you go up for those who know what it means. And with regards to VR, I don't really have an opinion with regards to the informed consent, but rather generally that it could be an interesting tool to combine for therapeutic reasons.
Yeah, so my thoughts on that. I think I generally agree. I think as a clinician doing the informed consent process with participants in clinical trials, I've never felt that how I'm consenting or the process by which it is done is unethical. I think it's in line with how we consent for treatment more generally. We give a sense of the risk, we give a sense of the potential benefits. We also obviously counsel that there could be harms, there could be side effects, there could be no benefits. And we do counsel people about what the experience might be like. And again, we've talked about how that's not going to be fully representative, but we give a bit of a sense of what it will be like, and that it can be quite challenging. And we also do tell people to not change jobs after their experience if possible, not to make big life decisions after they've had the experience, with a view that there may be some kind of fundamental change. But I think that, if you gave someone a kind of standard antidepressant and they had a kind of life-changing moment when the depression lifted, I don't think you would argue that they didn't consent for that to happen with the point where they were given this antidepressant. So I don't think that I agree with what's been said. I think with the VR thing, I think it's a really interesting point. There's been suggestions raised that VR could be an interesting placebo arm in psychedelic trials. Rather than having a sugar pill, you have a VR experience of psychedelics. I think without being an expert in this kind of tech, I feel that the visual experience, which I think the VR would be mostly trying to augment, is the least interesting aspect of a psychedelic experience, at least when we're talking about its therapeutic intent. I don't think that the wavy lines, the walls breathing, the kind of spectral patterns that people see when their eyes are shut are in any way related to any therapeutic response. I mean, they contextualize the kind of whole experience, but I think that the emotional changes, the cognitive changes, the changes in way people are thinking, the insights, the sort of processing of memories is much more important. So I don't think you could mimic that with VR at all. So my concern was if you said to someone, put this on, this is what it's going to be like for you at the consent process, they're only getting a very, very small snapshot. And in fact, in my opinion, of the least related part therapeutically to the experience. So I don't think it actually adds anything really interesting. And then there is a danger that it could give people a false sense that, I'm going to feel like myself, just see things that are different. And that's not the case.
Yeah, that's very interesting. In a way, it's then maybe more dangerous and more compromising of informed consent than if you say, look, this is just a chasm across which you must leap. Do you want to leap across the chasm? So I think it's and as you say, Matthias, I mean, people undertake transformative experiences all the time. I guess it's one thing for people in their daily lives to, by just moving through the process of their lifespan, be transformed. But it's another thing to then sign up for something where there's a kind of clinical outcome or a research outcome. And, do people want their life experiences to be instrumentalized in that way? I'd really like to turn to this question of patient vulnerability in psychedelic research, because it seems to me a really interesting one that's sort of double-edged because, I think, Daniel, you've written about this too, in terms of how the suggestibility of patients under psychedelics is kind of probably implicated in why they're effective. But then I'm wondering I'm curious about the panel's views on whether research subjects in psychedelic research are uniquely vulnerable, and are there special protections that might be necessary that are not necessary in conventional trials? Or is this once again a case of it's sort of similar to what we have to do, just perhaps amped up? Like, I guess, is this what we seem to keep coming back to is this notion of psychedelic exceptionalism. Are psychedelics an exceptional case in pharmacological research, or are they just an extreme case, but on a continuity or a spectrum with other pharmacological interventions? So yeah, I guess this question of kind of patient vulnerability and whether special protections are required.
So I guess I start. I'm not sure whether it is like patient vulnerability, whether it is exceptional in psychedelics or whether it's just very much enhanced. But still, I think two aspects are quite unique in psychedelic assisted therapy. So the first one is the experience, the psychedelic experience, which is emotionally very intense and can be turbulent and difficult and challenging. And you cannot really steer it. So of course if it gets really bad, then you can get a a drug that takes the psychedelic experience away, so to say, but this is only in worse cases. So normally you cannot really stop it, and you should also not stop it, but try to go with it. So that's, I would say, rather exceptional or rather unique. And then the other thing is like the suggestibility, even though there's not so much evidence on it right now. So it's really a topic many people talk about in the field, but actually the evidence is still very preliminary. So we do not really know how much suggestibility is enhanced, but still there are cases. Also in Switzerland, there has been like this case with the Kirschblütengemeinschaft that is like a culty group where psychedelics have been used to kind of manipulate people into certain directions. So this is a concern, and due to this concern, there are like special measures discussed that could be used. And one of these measures that I find interesting is, for example, to bring, if you have someone that you are very confident with and that you know well, that you can bring this person maybe to the psychedelic session, and this person then can comfort you when you have a very challenging experience. So it's not the therapist that has to comfort you, which can be transgressive potentially, but it's your friend that you bring, and your friend can also be just generally a source of safety and a source of safety during the trip, and your advocate, so to say, during the trip, and be there for you. Of course, this person has to be selected very well, so that not stuff is coming up between the two of you during the trip. But I would say that could be at least something valuable to put some research into it. And I'm wondering what the clinicians think about this idea.
I think from my point of view, if I was the regulator, I think this aspect is the thing that I'd want to pay the most attention to when we're thinking about how we might or would ever introduce psychedelics into mainstream practice. I think it's the feature or the kind of interplay with suggestibility, which I think is really something to consider. It also, even at this stage where we're in relatively early phases of research, there are already some anecdotal, some publicized accounts of sort of sexual behaviors from therapists towards patients in psychedelic trials, and also vice versa as well. And perhaps there's something about the sort of intensity and the vulnerable state and the processing of trauma potentially that brings out these aspects. And it would make me quite anxious, I suppose, as a regulator, to think about how we can mitigate for these things happening. I think that these things are on a spectrum. Again, you might see these kind of dangers or potentially complicating factors in kind of standard psychotherapy, but it feels a bit more like it's just more chaotic and intense with psychedelics. So I think there needs to be really a lot of attention paid to how we regulate the people working in the psychedelic field. And there has been some cowboys working in the psychedelic field, that's for sure, already, and we're just at a very early stage. So thinking about how do we ensure that people have the right credentials, the right intentions, the right experience to be involved, both from the medical side, but also from the psychotherapeutic side, I would argue is the most important factor. How we do that explicitly, I guess I'm probably not the best place to sort of suggest things, but it's something that I would care more about than necessarily the RCT evidence, for example. So yeah, I think it's a really important thing to consider.
Interesting. Matthias, do you have any reflections on this subject?
No, I agree very much with Matt. So I think the vulnerability is most likely already increased with psychotherapy itself. So, I mean, opening up always with same therapists, etc., etc. So certainly psychotherapy per se would be a risk. And if we add the psychedelics, producing feelings of closeness in patients, misinterpreting in some aspects, of which they should be informed prior to taking the substance, but at the same time, it clearly increases the risk of inappropriate interactions or whatever. My guess would be that the risk increases not, yes, with the psychedelic, but also with the psychotherapy. So the more psychotherapy we have, the more convinced the guys are, the therapists, that you need additional touch and things and whatever, and go through whatever, you have to go through a situation again or something like that. That would then make me anxious. Whereas if you have more a pharma environment with reduced therapy, just giving the drug, just assuring the safety of the moment, essentially by reacting to anxiety, but not doing other interventions. Maybe you even may have persons present, trip sitters, that do not have a long-standing relationship already with the patient. So one model could be that the psychedelic trip is actually with more neutral persons, but then the next day maybe you go back to the therapist, and so you kind of take these two things apart. But I agree, there is a risk, or there is an increased vulnerability and then and an increased risk here. And it may be different in the studies compared to the clinical practice, because increasingly with studies, the requirements are that one person is in the room, and then you may even be required to have another person that then protects the patient from person one, and then you start thinking who protects the patient from person 2 and 3 and so on. So we end up with video surveillance and a lot of things that are strange. It's also interesting to know that these aspects change depending on the country. So, for example, I think in Australia, you need a woman and a man present. The same was the concept in the MAP studies, like with diets present, but for psychotherapeutic reasons, actually. In other countries, or also in the US, you need 2 persons present, or video surveillance, or another person outside the room, and so. And in the Swiss limited use program, where around 100 practitioners are treating approximately 1,000 patients per year already in clinical practice with MDMA, psilocybin, and LSD, a single person can treat these patients. So it's not that you need 2 persons. There's often group therapy. So you have a group of patients and several therapists present, but there's also single therapy. And there is no requirement that you need a second person in the room protecting the patient from the therapist. Because if there is an issue with the 2, you could argue it's already there without the substance.
I'm struck sort of talking through the kind of implications, sort of ethical and practical, of psychedelic research, that some of the takeaways from the discussion today, I think are, getting the evidence right, getting a better standard of evidence, enhancing therapeutic effects, understanding therapeutic effects. I mean, a lot of these new designs and like factorial trials and so forth, they do sound a lot more complicated. And I wonder what the implications might be for the progress of psychedelic research. And is there a risk that in trying to solve one problem, we then create another one? Like, will it slow things down? Is there any concern around that? I can see Matthias shaking his head and Matt nodding, which suggests there might be an interesting point of difference there. Matt, I might bring you in and then Matthias can reply.
Yeah, I think, again, it's, I'm not saying I have the answers, and I think it's complicated, but I think that and I think there are ethical arguments to be made that we should be trying to bring psychedelics into clinical practice quickly, because some of the trials have shown really massive improvements in people with kind of treatment-resistant problems. I'm not sure I agree with that stance. I think it is, it has some logic to it. I think that we need to actually slow ourselves down a little bit, remind ourselves where we are. I mean, I'm talking obviously from a UK perspective here in terms of the evidence of psychedelics. We're still very early days. Because there are so many contextual factors, so many interacting factors, there's lots of things that we need to look at research-wise to kind of discern what works and what doesn't. And this will help to sort of bolster the evidence and kind of give us time to think about how we then, if these are regulated, how, or they are approved, how would they be regulated, and what it would look like in a kind of clinical setting. I think one thing we haven't mentioned is how, other kind of things like testing psychedelics when people are anesthetized to see whether or not it's the pharmacological effects without the subjective effects that are necessary for improvement. That might be testing, just the pharmacology side of it. We've talked about how we need to have a look in a bit more detail about whether and in what way psychotherapy is necessary or is it not. So there are lots of things that we need to do to probe this before we press on with kind of pushing for these to be regulated, in my opinion.
Matthias, did you want to jump in there?
Yeah. No, I think the companies will conduct rigorous placebo-controlled studies. They will not control for all these factors, or they will just keep them more or less stable. So we don't need we don't need to understand the mechanism of action in order for the substances to be approved as medication. So that's important. So this is more an academic thing. We just need to show the substances are effective compared in the end to no substance, which is essentially the placebo. And but it's interesting. Do we need a psychedelic experience? Is it just something else happening in the brain, or having a psychedelic experience without any psychotherapy, which would be my guess? I think we need the psychedelic experience in order for the substances to have therapeutic effects. Well, sorry, but I don't think we need the psychotherapist at this moment. He can do his thing later on if needed. So these are different views. But the companies that bring these substances to the market will probably just select their designs that they have to with the regulator and run the necessary studies. So to some extent, it's taken out of the hands of the academia already, because the academia will not be able to bring up the money and the rigor to kind of run the really expensive studies.
Thank you. I'm very conscious that we've sort of approached the hour. I just wanted to invite the panelists to make any other concluding remarks. If you feel there's an important point of view that you wanted to get across in this conversation that we haven't had a chance to address, it tends to just race by. No? Well, look, thank you all for this really enlightening discussion. Look, I think it's been really fascinating to unpack some of these creative approaches to strengthening study designs, without overcomplicating the process and falling prey to psychedelic exceptionalism. We've also had a chance to discuss some of the ethical dimensions of the question: informed consent for transformative experiences, patient vulnerability, the role of therapists. And I think what we can say is that, the conversation today reveals how psychedelic research does really blur the boundaries between pharmacological effects and psychological context. And it's really fascinating to explore the implications of that. So thank you all for your engagement. Thanks to everybody who joined as a participant. And we hope to see you at the next meetup. Thank you all so much for your time. Bye-bye, everyone. Thank you.